Hello, distinguished colleagues and members of the Ukrainian Spine Society. It's a great honor to join you today. I'm Jin Sung Kim. You can also call me Luke. Today, I'd like to discuss versatility and rapid rehabilitation by total endoscopic compression for complex lumbar stenosis, focusing on how can we utilize bipolar endoscopic compression to manage complex lumbar stenosis without traditional fusion. Here are my disclosure. I serve as a consultant for several endoscope industries and also the deputy editor of the Neurospine and Global Spine Journal, also the member of the NAS International Strategy Growth Committee. To give you a brief background, my journey with the spinal endoscope started back in 2006. Over the last 20 years of uniportal and 11 years of bipolar endoscopic experiences, my philosophy has evolved. We moved from the simple discectomy to advanced fusion. Since 2016, our focus has matured toward maximizing the efficacy and minimizing the structural trauma in complex cases. When we talk about complex lumbar spinal stenosis, we usually face three scenarios. The first one is combine the central and foraminal stenosis and multi-level stenosis, or severe isolated foraminal stenosis, especially 5S1. Traditionally, there are heavy indicators of open fusion, open decompression. Let's look at the case one. This is a combined stenosis scenario. Severe central stenosis at level of O5 and the left side primary stenosis at L5S1. My plan here was purely decompress, a biportal endoscopic over-the-top decompression for 4-5 and biportal parameotomy for 5S1 level. The patient was 80 years old, female, presenting with the severe low back pain and radiating leg pain down to her left leg and sole. Her baseline pain score for the leg was high, 7, and oscillatory score was 45, indicating the significant disability. This is X-ray. You can find it, a slight scoli and the vacuum disc and multi-level degeneration. And you can find it some sort of lateral subluxation at level 4-5, actually indicated fusion at this level. This is the MRI. You can see the foraminal narrowing at the 4-5 right side, and the central stenosis 4-5, and the 5S1 foraminal stenosis here. This is the clinical examination and neurologic status. The patient had the left dominant leg pain, claudication, and there is some sort of the motor weakness along the L5 nerve. So this is the radiologic diagnosis so far, and this is treatment option. Now, what are your choices for her, 80 years old female? Option A is lumbar fusion, either one level or two level, through the OLIF or MIT lip. This is very common lip flex, right? Option B is the compression alone. Given her age and pathology, we choose option B, targeted bipolar endoscopic ULBD at 4-5 and left side foraminotomy with far out decompression trigger. This is the plan for her. Look at the operation video. The navigation is not a mandatory, but sometimes I love to use the navigation to identify the exact target. This is left side approach at the level 4-5 over the top decompression. Firstly, you need to find the anatomy. Now, I already reached out to the contractor, the SAP of SAP under this endoscope control dissection of the and remove the real problem gentle manipulation of the dorsal dura and decompress the contralateral, the traversing, and also the contralateral exceeding nerve root. Right. So when the decompression was finished, we can find out the both side traversing nerve root as well. To avoid any complication, hematoma collection, usually put the drain through the walking portal. This is the another the level of the fibrosing foraminotomy. Sorry, the case of the foraminotomy, the video was not working. So this is post-op MRI. You can find a well decompression of the level 4-5 and some sort of foraminal decompression right side. Look at the CT scan. You can find the left side over top and the contralateral proximal foraminal decompression. You can see the lead, the indicator, and the decompression at level 4-5. This is the pre and post-op CT, right side foramen. This is the proximal the foraminotomy and valve decompression left side 4-5. This is clinical outcomes. You can see the improvement of the patient, the score and radiology, the alignment cytal balance improve as well. Okay, case 2 highlights multi-level stenosis at the level of 3, 4, and 4, 5. Again, instead multi-level instrumentation fusion, I performed the multi-level biportal endoscopic over the top decompression, achieving the full decompression while preserving the posterior tension band. Okay, let's move on to case review. I'm gonna show off the multi-level decompression as well. So this is the basic manner of how I hold the scope and endoscope. Look at this patient, 62 years old. She had experience of the previous treatment, many times steroid injections. Look at the pain score, FAS, back 9, the leg 9, ulcer 3, 70, the Q5 15, osteopenia. So you can find the physical examination, urologic examination, and the pain dermatome. Look at the X-ray. There's a slight recesses at the 4-5, but overall dynamic, no obvious instability. So 3-4 level, there's sort of the purging this together with the spinal stresses, and the 4-5. Yeah, there's a facet joint hypertrophied, severe stenosis. It looks like the patient might have the right rhomatosis. Look at the facet joint. This is hypertrophied a lot. And I love to use the bone spec image to identify the status of inflammation over the facet joint. Right? This is truly important. So diagnosis, say this is the impression from the images. Stenosis 2 level, 3-4 has sort of the rupture, disconnection, and for the recesses, also ulcerated 4-5. Some of you guys might be against a little bit the computer alone. You might prefer the fusion level. Fusion, the 4-5, especially 4-5. There are sort of the pros and cons between the fusion and among the sort of the decompression manner, microscope, uniportal, biportal. So my operation was the biportal 2-level decompression left side approach, right? This is we got flavum from each level, almost en bloc resection of the flavum, right? So let's play sets of 3-4 and 4-5 together. So as I already mentioned, the basic steps for endoscopic, biportal, unilateral laminotomy for the decompression. So now you are seeing the process of creating true walking portal, right? I already started the cranial decompression first. And so flavum is being exposed, right? from the midline down to along the inferior margin of the cranial lamina. And then I decompress the caudal side of spinal junction and the base of, the base of spinal process right here. Bring up the Carson and the drill. Let's go further. Yeah. Valve was pulled and removed, and then you can see the traversing L4 nerve root. Look at the profile there. Right. So I see the contractile traversing L5, contractile L5, traversing. Okay. So look at the result. Keep the postal MRI, well decompressed. I didn't remove the disconiation. I believe the canal decompression just to elevate the cloud cage and leg symptoms. You can compare the pre and post-op with the 4-5 and the 3-4. Both the pain score over time right after surgery. 9-4, 9-1. Very acceptable. Decompression was achieved at each level. And pain score as well. This is the skin incision. You can see the 3 separate incisions, right? So middle incision in the middle side. I use it for walking portal at the 3-4. I use it this incision for endoportal for the focal decompression for sure. You can see the improvement of the site alignment, collagen alignment well. So 30 months later, I followed the MRI again. You can see the beautiful remodeling of the spinal canal. You cannot see any of the obvious muscle damage at each level, right? So this is brief review of the surgical text. Now let's move to the case number 3. This is a revision case with the severe multi-level foraminal stenosis at both levels, 4, 5, and 5%. Right side, we plan bipolar endoscopic foraminotomy. So 71, female patient with a history of microdiscectomy 30 years ago, and a transplant endolumbar discectomy by myself 4 years ago. She presented with remnant severe right leg pain and walking tolerance of only 20 meters. Okay. This is the clinical neurologic status for her. And let's see the image. We can find a MRI and CT having the foraminal stenosis. The tip of SAP actually impinged the 4 and 5 together. This is 5% level here. And also the patient has multi-level vacuum disc and the back muscle, the atrophic status. So for pre-op planning, it is so crucial to identify the real pain generator and the key image like this. So you can say which level affected and which level should I go further with the surgery, decompression, before 5 and 5S, right? So there are sort of the different opinions among the surgeons. Some of you guys prefer the fusion and the other guys prefer the decompression. If you're going further for decompression, there are several different options, transfer uniportal, foraminal access, interlaminar access, and biportal or microscope open, microtube, etc. So there are sort of the different pros and cons of each surgical techniques. So what's your opinion? Of course, I did the bipolar endoforaminotomy to access the 5S. This is the endo and the walking portal you can see because of the 2 level. So the three separate incision is just enough. You can see the incision at the middle used for walking and the endo portal for each level. This is see an image, you can find it. And let's see the post-op image. You can see the well and decompress, the fibrillation and the full fire, etc. This is clinical outcomes, very tolerable, acceptable, right? So to wrap up, so when we face the three complex cases combined multi-level or paralysis, our traditional surgeons' brain reflex is open wide decompression and fusion. But bipolar endo changes this paradigm. Its excellent visualization and tool freedom allow us to bypass fusion. Remember, we do not need to treat the entire radiologic disease. Our focus must be precise, target, and eliminate the true pain generator. This is a true meaning of versatility in rapid rehabilitation by preserving the spinal stability and minimizing tissue damage. We achieve faster recovery. In challenging healthcare environment like the one you are facing in Ukraine, this strategy is highly valuable. It requires no expenses, implants, save the critical medical resources, and minimize the hospital stays to maximize bed rotation. So my final takeaway is don't overtreat. Focus on resolving the exact pain generator as minimally invasively as possible using the bipolar endoscope. Thank you very much for your resilience and thank you for your attention.